I'm delighted to introduce Frank Hester, who's the founder and CEO of the Phoenix Partnership. Frank has been invited on numerous occasions to address government trade missions representing the UK health industry around the world. He was named on the Queen's New Year's Honours List to be awarded with an OBE, that's the Order of the British Empire, for his services to healthcare. Frank is going to be sharing his thoughts with us on AI's role in combating inequalities in health. He's on stage already. Give him a round of applause, please. All right.
Thank you. I think that's the best introduction I've ever had. I want to talk to you today about AI in healthcare. I'm a computer programmer by trade. I got into healthcare accidentally because I married a doctor, GP, and it's very, very easy to be inspired by doctors. I've been working in this industry for about 21 years. And it's a very easy thing to get up in the morning and do. I'm from the UK. We have a computer system that looks after medical records, your allergies, your drugs, all that kind of stuff. When we started, I wanted to take away the administration burden away from my wife, and I didn't have much more vision than that. I didn't know anything about medicine, and I want to share with you an interesting anecdote that I discovered from the start and then apply that to some of the things that are going on today. So about 21 years ago, we got to the point where, although most people still had a computer system in a hospital or in a GP practice or in a community unit, we got to the point where really, really, the computers were capable of working over millions of records, you know, like right across the UK. I wanted to design something where the patient record was available everywhere. And as part of doing that, we also put in a messaging system for doctors so they could communicate with each other. And after we'd been doing this for about a year, we connected up some GP practices, some emergency departments, diabetes unit was a big part of it. We were working in a deprived area in the UK called Bradford. And I got a call from one of the GPs and they said, "You've got to come out and see this." And I forgot this bit. And it was this thing, and I didn't know what this, for those of you who don't know what that is, that's a blood test that's to do with diabetes, and there my knowledge ends. And what was happening was the GPs were communicating with the diabetes centre, and that was one of the communications. And the point of it was that before our system was in, it would be a long letter saying, "Dear Dr. So-and-so, I've been looking after this lady for 20 years, and you know, she's on these drugs, and her HbA1c has just dropped or increased." And a rather long letter, you know, "And what do you advise?" And then that would go, or the patient would be referred to the diabetes centre, and then they would do something and write a long letter back. And this was the replacement for that long letter. And I can't remember, the answer was either increase metformin or the doctors here will know, or lower it or something. And that was it, about 2 phrases. And I kind of pretended to understand it when the doctor was telling me, and I was like, "Oh, that's absolutely fantastic." But I went home to my wife and I said, "What on earth is this about?" And I said, "Why is the diabetes nurse involved in this? Does that doctor not know what they're talking about?" And she explained to me that, you know, her profession, she was a general practitioner. She knew a little about everything. And she explained to me that the diabetes nurse knew more about diabetes than her. And what we'd accidentally walked into was a way of amplifying that the diabetic nurse's voice right across a region. And we were helping solve some inequalities. Not by getting more doctors and more nurses, but just through technology. We didn't mean to do it. We discovered it by accident. And I spend a lot of time going around the world now, and I haven't been to every country, but I haven't been to a country where they've said, Frank, we've got too many doctors here, we've got too many nurses, we need less doctors. We have a shortage of clinicians, and we've got growing healthcare demand. And we've got massive inequalities. And I think you all know this. I'm just going to share some things that are surprising to me. Where I'm from, the UK, our capital city is London, and if you start in Westminster, where the MPs are working very hard at the moment, and you travel along the tube away from Westminster, each tube stop is 1 year off your life expectancy. And I think I live in a developed country. I'm pretty proud of our healthcare service. I think our doctors are great. But that's a bit of a startling statistic. Another one. If you have a learning disability in my country, you're likely to live 18 years less. It's not even a medical condition. It's just the case. And as we go out across the planet, over 2,000 children die every day of diarrhea. And whilst I'm not a doctor, I know that's readily treatable. Most of them are not in developed countries, they're in developing countries. So, I kind of want to talk to you about, think about that diabetic nurse's voice and how it got amplified by accident. And now, when I started working on AI about 2 years ago, and I'm impossibly excited by it. I genuinely think it's another tool to put in the doctor's bag. Without exaggeration, I think it's as important as penicillin or vaccinations. I've seen the power of it. I've seen what it can do. But we've got to get it in the right place at the right time. And that's kind of what I want to talk about today. How do we amplify the voices of all the doctors and nurses to help with those inequalities that we're seeing all around the world? And, I live in the UK. People are very, very concerned about privacy. To do AI, to build those big data sets, we're going to want every citizen, not just in the UK, all around the world, to allow their data to be put into research. Because what we want is the data. And we're living in the Facebook era, where people have become mistrustful of big data, and they want to know it's going to be safe. In contrast, last week I was in the Congo, and I'm going to talk to you later on. The first AI we developed was for ovarian cancer, and we're very pleased about that, and we're getting early detection of that. But there's no point in East Congo, giving a lady a smartphone and saying, we think you've probably got ovarian cancer. Because the healthcare pathways aren't there at the moment to actually manage that message and get the right treatment at the right time. What they're concerned about there is obviously clean water, diarrhea, bandwidth. It's technology. We need connected networks to deliver our AI. And engagement. You can't just walk into a country and start predicting cancers for the population without engaging with the government and, more importantly, without engaging with the clinicians to get the message across right. Language. And I know everybody, it's kind of obvious, but we're working in our labs, spinning up the AIs for early detection of cancer, stratifying diabetes, but then how does that message work in each country? About 3 weeks ago, I had the fun of being in a place in China called Chongqing, and I was interviewed by Chinese state TV, and everybody in Chongqing was really friendly, just like you guys, really nice. And I got asked, what do you think of Chongqing? I said, it's really friendly. I said, it's like one of the biggest cities on the planet, but it feels like a village. There was shock and horror. What I just told the Chinese inhabitants of Chongqing was that they were peasants. They were beneath me. And it was quickly, coloured in by somebody else saying, Frank means he feels at home. Now, that's a rather trivial example, but you can see how us techies spinning up the AIs could easily give the wrong message across multiple countries. And it won't be so funny if it's cancer and we give the wrong message. Right, ovarian cancer. We got into this. Our Prime Minister at the time, Theresa May, about a year ago, set a challenge for the country, said early detection of 4 cancers: ovarian cancer, bowel cancer, lung, and prostate cancer. So we kind of started work on that, and it helped give us a focus. And within about 8 weeks, we were very, very pleased with the results. For 50% of women, and I'll focus on ovarian cancer, but the results are kind of the same for all the cancers we were looking at. For 50% of women, we could spot the ovarian cancer before the GP could spot it. Now, we were absolutely delighted with that result. That's fantastic. And, we know that that's going to save lives across the UK. We know that's going to save lives around the world. But then, how do we get it out there? We can't just bang it on a smartphone. We know that. What does it mean to a lady to say you've got a 55% chance of ovarian cancer? We can't just put it around the world because we don't know what the pathways are in China, in South America, or in the Congo, or indeed if there are any pathways there at all. So I'll tell you what we did in the UK, and hopefully that will give you some pause for thought and maybe think about how we can apply it to other countries. We went to our clinicians, and said, look, this is what we've got. We think hopefully it will give you a nudge. We can put it in at the point of consultation. We talked about that. The problem with that is the average clinician, GP, anywhere in the world in primary care is going to see about 5 cases of ovarian cancer in their whole career. Usually in a consultation that's lasting about 7 minutes. So we could start doing this, and then randomly some GP in about 4 years' time is going to see something, and they'll have forgotten, what it is, what it meant, what the percentage means. So we decided to do it kind of as an after thing, running reports, and we're getting specialist GPs in each area who are looking through the lists, who have an interest in ovarian cancer or prostate cancer, to work through and go, yeah, that one's right, yeah, we've missed that one, no, I think that one's bowel cancer. And again, rather than putting it into the hands of the patient, the best person in my country is the doctor to deliver that message. And one of the problems with software is we can put up as many messages in front of doctors as we like, but they get alert fatigue. They stop reading them. It becomes meaningless. And, whilst we might think we're very clever saying, 55% chance of ovarian cancer, 30% chance of prostate cancer, 2% chance of bowel cancer. Once doctors have seen that for a couple of weeks, they're not going to really hear the message. And I think our challenge with AI is getting that message across at the right time, in the right place, and making sure we change the outcomes. So, I know that people are doing AI all over the world, but it really does I was looking at the list of companies out there, and it's a very, very impressive list, and I've been very impressed and inspired by the talk so far here. So thank you to the guys who've been doing that. However, it does fall to us, to deliver this new thing, to put that into the doctor's bag. And we won't be measured on how clever the AI is, how fast it is. We'll be measured on the outcomes. Did we fix the inequalities? Did we make it better? And I think we can. And hopefully that will help some of you. And I look forward to being here again, in 5 or 10 years' time, where we have delivered that. And I'll guarantee you it will be in a surprising way that I haven't thought about. But I think together we can really make a change. So good luck to us all. Thank you.
Frank, thank you very much indeed. Any questions for Frank, then please do raise your hands.
Thank you.
Of any of the content that you've seen here this morning, please raise your hands. Frank, you're going to be here for the rest of the day?
Yep.
So if anybody wants to catch you for a conversation, you'll be milling around.
I'll be outside having a cigarette.
There we go. That's where to find him. All right, Frank, thank you very much. Appreciate your time. Thank you.
Thank you, everybody.
Frank Hester, everybody.
Thank you.